Derek, do you have a few apologies for today?
Yes, today, Chair, we've got Kim Cruton has tendered apologies, as has Dr. Caroline Howard, Dr. Malcolm Metcalf, and Chris Littlejohn is still engaged with the response side of COVID.
Okay, thank you. So we'll note them for the minute. Do you want to do the roll call, Derek, so we can just know who's all on the call?
Thank you, Chair. Just advise all participants today that please note that the public section of this meeting will be recorded. It's later published online for public access. Can all attendees mute their microphone when not speaking and consider whether they wish to switch off their camera. However, the Chair does like to see members and participants where possible. The camera and microphone should be switched on when you are invited to speak. I will now ask for all members to confirm their attendance once their name has been announced so that it is clear in the recording of the meeting and can also be recorded for the minute. Chair Luan Grujon, I have already spoken to, thank you. Councillor Leslie Dunbar.
Good morning, Derek and everyone.
Good morning, thank you. Councillor Bell.
Yes, good morning, present.
Good morning, Councillor Cook.
Good morning, everyone.
Morning, Councillor MacDonald.
Hello, I'm here.
Alan Gray. Alan Gray did have some technical issues earlier. He sent me an email. We'll check with him shortly, Chair. John Tomlinson.
Yeah, good morning.
Good morning. Sandra MacLeod.
Good morning, Chair.
Alex Stephen.
Yeah, and I'm here and I've got an update from Alan Gray that he'll be here within the next 10 minutes or so. He's just caught in another meeting at the moment.
Thank you, Alex. Mike Adams.
Good morning.
Jenny Gibb.
Morning, everybody.
Morning. Jim Curry.
Yes, morning.
Jim Simpson.
Good morning.
Morning. Maggie Hepburn.
Morning, everyone.
Shona McFarlane. Alison Murray.
Good morning.
Morning. Alan Chalmers.
Good morning, everyone.
Morning. Angela Scott.
Good morning.
Morning. John Forsyth, I think, is representing legal today.
Morning, Derek.
Good morning to you. Is Jess coming along or is she not here today?
She's not here today. I'm providing legal cover.
Fine, thank you. Other authors and participants present out with the membership, Chair. And you do have a couple of observers, as I indicated to you. We have Councillor Cameron, one of the IJB substitutes, and we also have Mr McGowan, one of the chief officers from ACC, having a look in today as well. And Alan Gray has indeed just joined us.
Okay,
thank you, Chair.
Thank you. Great. Thank you. Welcome all. Great to see you with us this morning. I'll start with the important bits that we'll aim to have a break at about 11:30 so that people can have a comfort break then. Derek, could you just give me a bit of a nudge around that time so we can decide at what point, if we're at an appropriate point in an agenda item to break about 11:30. Okay, thank you. Do we have any declarations of interest for today? Not seen any. Are people shaking heads? Okay, so we'll note no declarations of interest. We don't have any exempt business for today. Correct in that? Yeah, just checking that's the case. So everything will be held in public. I'll just then move on to the standing items that we have. The first being the minute of the board meeting of the 25th of May. Can we take that first for accuracy? For members, are people content with the accuracy?
Yes, agree.
Yeah, people are happy with that. Do we have any matters arising that are not covered elsewhere that anyone would like to raise from that meeting? No. Okay, not seen anything. Okay, we also have then the draft minute of the Clinical and Care Governance Committee for noting. Leslie, would you like to highlight any aspects from that meeting?
Quite a lot of the focus of that meeting was around some reports concerning adult protection. So it was very good to see the Adult Protection Committee biennial report, which had been delayed for 2018-20. We also had a report on the Adult Support and Protection Inspection preparation work that's currently being undertaken for the inspection that will happen, I believe, next year now. And we also had a report around a case study, which I think gave us a really good insight into the challenges sometimes with multi-agency working around, people that have very complex conditions. So it was, I think, a really useful set of reports that came to us in the light of the pandemic and offered us a lot of reassurance around, the ongoing work with adult protection.
Thank you, Leslie. That's really helpful overview. Does anyone have any points they'd like to pick up or any comments on the report on the minute? John Cook.
Thanks, Ryan. Yeah, it was just on the report on managing self-neglect and non-engagement. My colleague Audrey Nichol MSP had got the report through the Drug and Alcohol Partnership and was asking me about this. And the question is around the amount of training that's going on with this one, because the report itself, having looked at it, it looks really good stuff. But when multi-agency work is happening, that tends to be when things can fall through the cracks. And some of the stuff looked, it's quite a meaty document. So I was just wondering what training we've done to get this out there.
Thanks, John. I'm wondering, well, I see Claire's here. Claire Wilson's got her hand up. I'm hoping you're coming in, Claire, on that one. Thank you.
Yes, thanks, Chair. So just in terms of the self-neglect and hoarding guidance, there was a big event that was held, Councillor Cook. So we had a big event a couple of weeks ago. We had nearly 200 people from across the partnership, council, fire, police, loads of the third sector and private sector. So that event was actually recorded. So we had the national coordinator had came, we had a GP, there was myself. It was recorded. So the training, well, the event is going to be shared, and it has been shared online in many forums. It was recognised that this is our first kind of step. It's the first framework we've had for professionals to work together, really just on the complex issue of self-neglect and hoarding. And we appreciate that as we move on, there'll be lessons learned. We're working very closely with the national coordinator in terms of models that we can use, and if there's any appropriate training, but it's definitely a first step, and the event was really just to launch it, and there'll be further opportunities for learning. I hope that answers your question.
Yeah, it does. That sounds really good and really reassuring. So well done.
Thank you.
Thanks, Claire. Okay, I don't see any other hands up on the Clinical Care Governance Committee, so I'll move to the draft minute of the Risk Audit and Performance Committee. Again, just here for noting. John, any items that you'd like to bring to our attention or to highlight?
Thank you, Chair. Just the fact that the audited accounts were approved, so that's a significant step. That's on page 27, and then I think it's worth highlighting page 29 of the pack, the shift to leadership team objectives, the further report on that, and the committee is looking to see how there's a joining up between the performance indicators, Operation Home First, the LOIP, and the strategic plan based around those objectives. So I think that's been a helpful report, and I'd encourage other members to maybe take a look at those objectives in terms of the joining up. And there's going to be reports to the next 3 committees as that develops.
Thanks, John. That's really a helpful overview. Any comments or questions from any colleagues on the RAP? No. Okay. Not seen any hands. So I will now move on to the business planner. Alex, are you going to speak to the business planner today?
Yeah, I will do, Chair. There were a couple of it. There's obviously John Tomlinson just spoke about the accounts. So the audited accounts and external audit report were agreed by RAPC. That's within their terms of reference as a committee, and I said at the meeting that once the accounts have been finalised and the audits and signed and so on, that we would get those sent round the IJB, so the IJB have a copy of that for their own information. It will not come to the IJB as a paper, but you'll get a copy of that along with the auditor's report. The financial monitoring will come in August. Looking through the rest of the vaccinations, we've decided to delay that one. And bring it back in August because there's some work that's being undertaken by NHS Grampian to look at the vaccination programme across the region. So continuing discussions there, and also discussions around funding for some of the vaccination programme as well. The 2C redesign project update is within the CEO report, and then all the other papers are in your agenda pack. There was just one amendment to November. We are bringing a primary care improvement plan up review report to the RAP committee over the next at the next cycle. But this we want to bring a further report back to the IJB in November, so there'll be an addition in November of a review of the primary care improvement plan for the city. That's all I was going to say, Chair. Happy to take any questions.
Thank you, Alex. So just if I can, before I open it up, just for clarity then, there's a report on primary care improvement plan coming to RAP, and then we're going to have a paper coming to the full IJB in November. Is that correct? I've picked up properly.
Yeah, that's correct.
Okay, thank you. I'll open that up for any questions from any other colleagues on the call. No, I'm not seeing any hands or any comments. Okay. Thanks, Alex. That's a helpful overview. Okay, we'll now move on then to the Chief Officer's report, which there's a lot of information in. I'll hand over to Sandra to introduce her report today. Sandra.
Good morning, Chair. Thank you. Just minutes. Okay, it's the Chief Officer's report provides an update to the IJB, and I do appreciate that IJB members will have read the report. I would not seek to go through it point by point. However, I'm aware of the, as you say, about the lot of information that is in the report and lots of the reports that you have before you today as IJB. So there are 3 key messages within this report, which when considered collectively can provide some context for the current environment in which the IJB and the Health and Social Care Partnership teams are experiencing, which may be worthy of the board's attention. One is that primary, secondary and community care are delivered within a new normal, which reflects our experience of living with COVID. Number 2, second point is that expectations of individuals about what can be delivered safely is sometimes at odds with what we can be delivering. And at the third point, the services are adapting, they're developing, they're redesigning and they're responding at pace, but within the capability and capacity of a public sector which has been frontline in the struggle against COVID for the past 16 months. We acknowledge that we have been living with several waves of COVID since March 2020 and continue to do so. It's impacted on our ability to deliver in traditional ways, the right care, right place and at the right time. We have staff teams who have been working tirelessly during this past 16 months and continue to do so. We have citizens who have been through an isolation period, numerous of those, and who have not been able to access services, supports and social benefits as they did before. Many primary, secondary and community care services have had to change in how they are delivered, and we have embraced digital, telecare, near me and e-consult technology. We would like to assure the board that services have not moved to uniquely digital technology or near me. Face-to-face appointments across primary, secondary and community care continue to be provided where essential to patient care. We will be working closely and collaboratively with citizens, partners and the IJB as we progress with our digitalisation, and that we are mindful of existing and potential inequalities and will deliver improved access to services for all. We would acknowledge that there are less available appointments for face-to-face, and that this is due to social distancing, safer workplace changes due to COVID, and how we have had to adapt our GP practices, clinics and community spaces to reflect the changes brought in to protect each of us. Face-to-face appointments are being used when it will change the management of patients. The risk within primary care, and in particular GP practices, is that we still have many vulnerable people accessing them, particularly for nursing reasons, and that if any asymptomatic person was brought in, the risk to an outbreak within a surgery could be devastating. The LMC, which is the local medical council, are actively encouraging GP practices to continue triage and only have face-to-face when needed. Practices are now up to and over pre-COVID levels of appointments, with some practices reporting at 150% of pre-COVID. Primary care, as with community and secondary care, continues to have staff absences due to isolation, which again impacts on our delivery. We do appreciate that for individuals, the new ways of working can seem difficult. People are at times struggling to overcome or learn new technology or ways of seeking appointments. And we are all learning in this new way of working. We've had to introduce technology at pace, and we are working with partners and our communities to continually learn and improve. Our collective teams across Aberdeen City Council, NHS Grampian and Aberdeen City Health and Social Care Partnership are collaborating with communities to ensure we bring sustainable, future-focused and future-proof services to the citizens of Aberdeen. We're actively seeking support of the media to bring real-life stories and situations to the public to share the changing systems and methods of delivery. The report you have highlights how we continue to strive to deliver the right care at the right place and the right time. There are changes to how we can deliver, for example, respite and interim arrangements to support people at home and coming out of hospital. The award of the tender around the management arrangements of the 2C practices. This will bring increased sustainability of the system. It has created larger practices which will be more robust and efficient in their delivery. And we are working currently with patient groups around a redesign of services around the Marywell practice, and a fuller report will come back in November. We have and continue to adapt to the changes within our environment. The work around vaccination cold spots has brought new and really positive working relationships between teams and community groups. The collaborative working across the public sector has increased as we learn from each other and learn about different community groups which are more diverse than previously exposed to. Our staff teams continue to deliver the approach and quality services that the IJB strategic plan directs, encouraging these within the partnership. Hospital at Home was specifically referencing a recent published research article by Dr. Callum Least and Catherine Carajuli, and it highlights the approach and benefits to patients and to staff. We continue and have increased our focus on staff wellbeing, mindful that the majority of our staff teams are frontline and continue to be frontline in ensuring that we deliver services. We fully acknowledge that people are looking to get back to normal, but the new normal is not the same as the old, and we need to protect those that are vulnerable, those on the front line, and those who are working behind the scenes to ensure that we can continue to deliver. I would reiterate that primary and secondary and community care are delivered within a new normal which reflects our experience of living with COVID. The expectations of individuals about what can be delivered safely, unfortunately, is sometimes at odds with what can be, and that services are adapting, redesigning and responding at pace within the capability and capacity of a public sector which has been in the front line of a struggle against COVID for the past 16 months. Thank you, and I'm happy to take any questions.
Thanks, Sandra. That was quite a helpful context setting for where we are right now. It feels appropriate, before I take questions from people, that can I just put on record that our thanks from the IJB to the staff that we have that are working in primary, community and in secondary care for the amazing hard work and perseverance that they've shown over the last nearly 18 months, and I know that they'll continue to do that. And I suppose, to be clear, when I say staff, I mean all our staff, our nurses, our doctors, our cleaners, our domestics, our porters, our link workers, our AHPs, our reception staff. Every single staff group deserves recognition and thanks for what they've done to keep things going under these really tremendously difficult circumstances. So if I can just ask that we record that in the minute on behalf of the IJB, that would be appreciated. Thank you. So I see now lots of hands up. I'm not sure which order they came in, so we'll go. I think I saw John Tomlinson first, and then we'll go to Philip, and then John Cook.
Okay, thank you, Chair. Thank you, Sandra. That was really helpful to hear that, and very much welcome the focus on the communications and the clarity. Looking at the GP practice teams 3.3, I'm just wondering to what extent the message can be a consistent one, or because if different GP practices have different approaches to this, and whether just how are you going to overcome potential confusion, or is it going to be quite consistent in the way that people can access them? And then I was just wondering to what extent practices might build up a kind of email contact and can then tailor their particular message to their own patients going forward, if there isn't indeed consistency across them as to what the pathways are.
I come back, Chair.
Yes, please.
Yep.
Yes.
So, John, I'll attempt to answer your questions. I think with regards to consistency, we are aware that our GPs are all independent contractors. They work within the recommendations that are provided for primary care. So there will be, as with any services, a level of different experience depending on different practices. However, fundamentally, the key principles are being applied. I do take on board that what you're saying about picking up with the practice population and how that population is working with the GPs, and I can certainly feed that back to our colleagues, and we can put that back to GP sub to ask about the consistency factor and to ask if there are communications that can come out. So I can certainly take that back, because it's a very valid point.
Okay, thank you.
Okay, John, thanks. Philip, I'll go to you next, Philip.
Yes, thanks, Chair. I think actually John Cook may have got in before me, but John's a gentleman. I'm sure he's happy for
age before beauty. Go on, Philip.
Yeah, I thought you might. So I was going to suggest that actually. Thank you. So a couple of questions, so John Tomlinson actually alluded to one of them, and that's in subsection 3.3 GP practice team communications. So the report, the section of the report says that there's going to be some Twitter and other social media events or information. I'm wondering how the general public actually know that is available to them. I don't do Twitter or social media or whatever. Terribly sorry, chaps. But I wonder if maybe you could just clarify that a bit for me, please, for an old duffer.
So certainly I'll come back to it. There's I think the report is leaning towards the explanation that there's multiple media sources being used. I'm more than aware that Twitter is not for everybody, neither is Facebook. Some people are on Twitter, some people are on Facebook. We're using their local, the media, Evening Express, the P&J. We're looking at multiple sources, very conscious. And I think the communications team between NHS Grampian and the Health and Social Care Partnership and UCC over the course of COVID have realised that we need to have multiple opportunities and multiple avenues for people to connect to. So the Twitter, if you're on Twitter, you would have seen the things, but if you're not on Twitter, you won't be missing the messages because they'll have been sent in different formats as well.
Okay, thank you. And presumably, if I was on Twitter, it would just pop up, would it? And I would know, oh yes, go to this.
It's just
if I was following it.
Yes.
Okay. Right, thank you. That's quite helpful. So the series of articles then in the P&J and the Evening Express, do you have any sort of timeline for when they'll be produced?
Some of those have already been issued. I'm not sure if I have Graham on the call to give give exact timelines, but yeah, we already have. We've had a few of our GP colleagues and certain things have done editorial pieces, thought pieces within there. I can certainly, I don't have the exact time and dates, but I can certainly send the links or share those after the meeting if that's helpful.
Yeah, thank you. Maybe I missed that in the P&J. Thank you. And then my last question is related to the piece on the 2C process update 3.9. I don't want to ask a lot of questions, but I'm just wondering, the P&J, this is an article in the P&J that I did catch, and it actually said that there was actually told the value of the contract. I'm wondering why that hasn't been included in this, what looks like a reasonably comprehensive update. Or perhaps that will be brought in the November the November report. Was that the intention?
The value of the contracts and things would have been submitted in previous papers when we were looking at the procurement process.
Right.
In the IJB. Yeah. So sorry, I didn't consider it whether it was relevant to be included in here. It was just really an update on where we were.
Okay. All right. Thanks. Thank you very much.
Okay. Thanks, Philip. John Cook, bring you in now.
Thanks. Yeah, it was just to make a very brief comment. Actually, I thought the report was very good. I thought Sandra's talk us through it was very good. I particularly liked again point 3.3 about the communication, which Philip and John Tomlinson have already mentioned. I think that's really important. I think there's some stuff that's going on where we're changing the ways of working because we haven't got any alternative. It's kind of a defensive response to COVID. But there's other stuff where, and I'm thinking particularly of things like Near Me, where actually it's something that we'd have wanted to do anyway, even if COVID hadn't happened. So I think getting the message out there and explaining what's happening and why it's happening is really important. So that was it. Didn't have a question for that comment. Thanks.
Thanks, John. That's helpful to get that feedback. We'll go to Sandra MacDonald and then Leslie Dunbar. Sandra.
Thank you very much, Chair. I was having a look at the 2C tender process at 3.9, and particularly around the second part around Marywell and how that might develop over the next wee while. And a project team has been set up. And I just wondered, towards the end, it says, Sandra, that there will be option appraisal brought back with feedback from service users, which is very welcome. I just wondered, will that also include feedback from staff in that options appraisal?
Yeah, thanks, Chair. Yes, absolutely it will. The project group has been set up as very much about a collaborative piece of work. And although it does state about feedback from service user, we are actively having patient participation in focus groups and things to really design the service. It is quite a diverse population that Marywell provided for. And I think since the links into Timor Market, we're really looking at what the opportunities present ourselves for about delivering and really reaching and preventing inequalities as we move forward. So absolutely frontline staff will have to be engaged around about this. And
Thank you. And I have a second question around communications. And my question is really about, there was a lot in here about things that have been set up and information given out. I'm particularly interested in how we intend to answer sometimes those, or to respond to Twitter, to respond to Facebook, because I think it's good to have these channels of communication going out, but I also think we need to be able to respond, and sometimes as public bodies we're not terribly good at that side of it, and I think that's something that needs to be if not hardwired in, certainly softwired in from the start, so that that is in place going forward.
It's certainly a point.
We'll come back on that.
Yeah, sorry, it's certainly a point I can take forward. There has been in some media contexts whereby we do seek advice on how we should respond to that. But I can certainly take that back and take that on board.
Thank you.
Thanks, Sandra. So I've seen a few more hands. Leslie next, and then I saw Mike, and then Alison. So go to Leslie.
Thank you, Chair. Thank you, Sandra, for your report, and I think a very comprehensive kind of introduction that you did there around the challenges that currently are being faced, but and maybe in particular around, you know, how we manage expectations. So I've got 2 points here really in terms of your report. The first one is also around 3.3 and communication. It appears, I think, that there is a challenge around maybe the messaging of how patients at GP practices perceive when they're not given, you know, like a GP and instead maybe offered, you know, what's seen as the most appropriate healthcare professional and how that's messaged to them. And I just wondered if you could maybe say a bit more around, you know, how, if there's a plan and how that might work in terms of getting that message out maybe more successfully to patients. And the other point is at 3.7, it's just to thank you, I think, in terms of the language that you're using, you know, you're talking about the vaccination cold spots, and I really welcome the way that you've used language here, Sandra, because often we see in reports mention of hard to reach groups. And of course, we all know that, you know, groups and communities are all there for each of us to very easily find. It's often the services that are hard to reach rather than the people. So I welcome and I hope that, you know, we'll continue to see more of this type of language and used in terms of groups and communities and services.
Thanks, Leslie. Sandra, do you want to come back on the question about public messaging?
Yeah, I can do, Chair. Yeah, the messaging round about the using of the multidisciplinary team has been both at local and national levels, Leslie, Councillor Brash, sorry, but we certainly have promoted that in multiple formats, and it has been, it's about who to contact. I think there's been there, but can absolutely take on board. I think it might well be something that needs to be repeated frequently, and we can certainly take back and go back to some of the simple infographics and simple messaging, mindful of Councillor Bell's comments earlier about using multiple media sources. So we can certainly take some of that back and relaunch with our comms team about how we could pick that up. And I'd also like to thank you for your comments on the language in the report. That's appreciated. Thank you.
Now, I can't see any hands now, but I did see at one point Mike had his hand up and Alison. Mike, is there something you wanted to come in, or has your question been covered?
I suppose part of it has been done, but it was some most of this is just comment. So I think it's a really good and helpful report. It really is. I think that we need to acknowledge more than anything else the extremely difficult challenge that we face mostly on staff and public expectations, because this directly impacts then on delivery, change and sustainability. And I think the communications is the most important stuff, especially if I'm speaking from a staff side point of view. And that is on the acknowledgement, the staff contribution, but also assurance on the processes that we are committed to carry out both delivery and change, despite the pressure that is put on us. But as I say, a helpful report.
Thanks, Mike. Alison.
Hi, yes, thanks. It's mostly about the GP again, GPs. I had a couple of questions. One was the appointments, they're both related, was saying that there's been a huge increase in number of appointments that GPs are dealing with. I was wondering to what extent that is driven by the e-consult process, by the electronic digital process, whether it's actually generating more appointments because of the nature of the process. Mother is about the actual interface of, I don't know how it is in other GP practices. In our GP practice, it's e-consult, and I've had reason over the last couple of months with all the children and myself to go through that, contact the GP probably half a dozen times, and only on one occasion was the interface appropriate for my consult, for my sort of being able to put in the information. And on that occasion, it involved a 25-minute questionnaire, which I then, after 20 minutes, ran out of power on my iPad and I had to go and plug it in and start again. And then the GP was like, well, actually, that's not relevant. And I sort of, well, I know it wasn't relevant, but I had to fill in this questionnaire to get on. And I was just wondering to what extent that interface between the public and the GP, the actual electronic interface, is being assessed and considered. Because certainly on one occasion, I just gave up and phoned up. And if it's putting people, it might be putting people off.
Thanks, Alison. Sandra, do you want to come in on those points? I don't know if you're able to answer the specifics.
I was going to say, just want to clarify. So the key question that I picked up from that, Alison, was about the electronic, the interface between the GP and the public, and how that's been assessed and considered for ease of use for the public. And I would appreciate if I could take that question back and respond at a later, just find out a bit more detail and come back to you with that. Do acknowledge the circumstances that you describe, and we can certainly take some cognizance of that and seek to understand how others are approaching.
The other one was how much
sorry,
might be generating additional appointments by itself.
Yeah. So I think the feedback from that is that there's a few specific GP practices that used e-consult prior to COVID. And I think that when we're looking at those practices, that, for example, that's the one that had used e-consult prior and is using e-consult now, and they've had 150%. That's the one that's had 150% increase in there. So it isn't the fact that it's e-consult prior or post. It's actually they've got the same system to assess pre and current.
Okay, thank you.
Okay, thanks, Alison, for those questions, and we'll have a note that Sandra will come back with some detail on how that's been assessed. Okay, John Tomlinson, your hand's up. Did you want to come back in, or was that from previous?
No, if I could, I just got a quick second question, and that's just to do with the long COVID. So I appreciate that the clinical part of this will be considered through clinical and care governance, but we're not sure yet the volumes that are going to be involved, but some reports suggest they could be relatively high. So I would welcome later in the year a further update so we can get a handle on potential resourcing issues for us and obviously understand the implications of this in due course. So it's just a simple ask, if I could make that. Thanks.
Thanks, John. Sandra, are you okay to go away and have a think about timings for that and where most appropriate for that to come?
I'm fairly sure it's already in the business planner to come back in August.
Okay, so just if we can, it's maybe a bit early there for thinking about the resourcing implications of it, but if we can, then that's fine.
Okay, so could just pick up on a couple of points. I think there's definitely two areas of the long COVID. So the one that's referenced to in the report is specifically long COVID for people who have been through ITU and been in hospitalisation in there. I wonder if, John, if what you're referring to is long COVID where people have had chronic fatigue and things like that and those symptoms and the resources for that. The team are currently looking at that as part of rehab. I think what we're very mindful of is that is creating and understanding conditions and the impact on our current service delivery and how we will manage those within our current remits and our current service delivery, rather than creating new pathways for new conditions, which, as we understand from multiple new areas that come through, that every time we create a new pathway for something else, it pulls away from a service in which we're already delivering. So the team at present are looking at how we can embed and understand and put that into current pathways. But we will seek in August to at least have an indication of how we plan to approach that.
Okay, thank you.
Thanks, John. Thanks for picking up the long COVID point. That's a really important one. Okay, I don't see any other hands up. Thanks for all those questions and discussion, and Sandra for a very full and comprehensive report. One thing I wanted to highlight was just I was really pleased to see that we're having a workshop on digital in August. I think that will help us have a bit of time to understand how digital will play a role in the future. and you know, be involved in helping shape that. So I really welcome that, and yeah, thank you very much for that report. I think it was important. We spent a bit of time on that this morning, so thanks everyone. Okay, I will now then move on to the first sort of paper under governance today, which is the independent review of adult social care. Who's speaking to that report this morning?
It's Claire.
Claire.
It's me.
Yeah.
Yes, sorry.
So on you go. Do you want to introduce that report, Claire?
Yes, I
over to you.
Yeah, I certainly will. Thank you, Chair. So this report is to highlight the publication of the independent review for adult social care, and it's part of the programme for government for 2020-2021. The report was published by Scottish Government in February and contains 53 recommendations to improve adult social care. I appreciate that the paper and the report is very large. I suppose from me just to note that it very much gives an intention, a statement of intent, and very much aligns with our strategic plan in terms of a new narrative for social care, focusing on achieving better outcomes, a human rights based approach, and obviously the ethical commissioning based approach that we use. At this time, it's very difficult to say what the implications of this will be. I know there's going to be extensive consultation over the next few years, but the board is asked just to note the report, and I'm happy to take any questions.
Thank you, Claire. And I think it's just a helpful putting it on the agenda for us and on our radar, but as yet the detail still has to be, you know, there's a lot of work to be done on the detail of what this is going to mean. But my understanding is our strategy is very much in line with the human rights person-centred approach. Yeah. So we're already progressing in the right direction.
Yeah. Absolutely, yes.
Okay. Thank you, Claire. Leslie.
Thank you, Chair. So Claire, thank you for this report. I think I've maybe got a couple of points. The first one's around there is mention of reformed IJBs. I take it that may mean that, you know, there'll be less IJBs rather than more. But I just wondered if you were able to provide anything, you know, like around that. And I'll leave it there for just now.
Okay, so in the report, yes, it does talk about the reform, and it mentions the IJBs. At this time, we don't know what that could look like. That was just a recommendation, and obviously there is going to be national groups that will be pulled together. They've already recruited social work advisors into Scottish Government who will be consulting and doing national groups around this, but it's difficult to say at this moment what that could look like, and if they go ahead with that recommendation, I just don't know.
Okay, thank you. And I had another question. It's kind of gone from my head there. It was just when you were talking around no, it's gone. Sorry. If I remember, I'll come back. Sorry.
You can come back. Yeah. We've got John Tomlinson and then Alan.
Okay, thank you. At paragraph 3.17, page 51, just makes reference to fully exploring the possibility of pausing local procurement meantime. Just wondering what our stance is on that.
Claire, are you able to come in?
Yeah, so at the moment I can't answer that. I'm sorry, John. You know, there is a lot of consultation, and nationally the chief officers group nationally have raised questions back to Scottish Government, but at the moment I'm not sure.
Yeah, see,
I don't know if Alex.
Yeah. See Alex's hands up. He might want to come in on that point. Alex.
Yeah, I mean, there is a discussion nationally about whether procurement should be stopped or not, and there is two schools of thought to that at the moment. But at the moment, we haven't made any decisions to stop as a result of this. Anything that we would have normally have been doing. but we do need to be mindful of the context of some of that stuff. So it's probably a case-by-case basis, but certainly at the moment we're not looking to stop anything that we would have otherwise done. As I say, there are two schools of thoughts around about that at the moment.
Okay, well, maybe just offline, I'll have a chat about what the rationale is on the two schools of thought. That'd be helpful, but that's fine for now. Thanks.
Alan. You got a sticky mute button, Alan. I'm wondering if Leslie's remembered. We'll go to Leslie next. Oh, wait a minute. I think Alan's come in. Are you
That's
there?
me. I've got back.
Yeah,
I've got
okay.
it now.
Come on, Alan.
Good morning, Claire. Thank you for the report. What it was about the service user involvement groups. You're looking into getting the service involvement groups up and running. Just to make you aware, I'm involved in a service user involvement group with Alcohol and Drugs Action, and it was just to make you aware if you're looking for any advice or any support. I'm available to help you out if you're looking for any support in getting that started up. And I don't know if you've already looked in how you're going to get it up and running.
So during the review, Alan, there was a lot of consultation with the report, and a lot of service users were spoken to, and as you'll see in the report, that's very much they want to continue with that and kind of use service users to really kind of frame the way forward for social care. So I welcome your offer, and I will take you up on that, Alan, certainly.
Thank you. Thank you.
Excellent. Thank you. Leslie, we'll come back to you.
Okay, thank you, Chair. It was around really the whole shift from the kind of marketisation, that we've seen of care services over, many years recently, and the move more towards, like collaboration, which obviously we've certainly started that journey. But I just wonder about to what extent, it seems to me that's quite a complex set of things to do. And the Scottish Government's talking about having an overview of, we've touched on this already, commissioning. But I just wonder, because even thinking about, there's a complexity locally in terms of, I understand we have maybe about 200 different or over 200 different commissioned services. So therefore, if this has been brought together and centralised nationally, it's what then the challenge is in terms of how all that's going to be, practically rolled out in the next, 5 or 6 years.
I think, oh, sorry, Chair, can I just come back in with a few points? And you're right, Councillor Dunbar, our care at home contract is very much about that collaboration between providers. As you say, it's very complex. It's difficult to know if it's just going to be a national framework that everyone works towards, or it's difficult to say at this time. I see views from a national perspective on it.
Well, I mean, as Claire's saying there, it's difficult to tell at the moment exactly what the recommendations are going to be around about that. But within Aberdeen City, we've, when we did that care at home stuff, we used a collaborative approach to how we tendered that. The other thing is that we're developing strong relationships locally, or we have done in the past, or continue to do so, I suppose, in relation to how we responded to pandemic and supported our providers around about that. And then last week we held our first meeting with a strategic group of providers to try and help them, or looking at our, looking at how they make influence on our market position statement and things like that going forward. So we are doing a lot of work in terms of working in collaboration with providers. We don't know at the moment what the national solution to that will be, or a national recommendation of that would be, but certainly I think within Aberdeen City we're on the front foot in regard to that recommendation.
Thank you, that's really helpful. I'm not really anticipating that you're able to give you know, like fully formed answers here. It's just to get an indication of maybe where we are in the process. So thank you again.
Okay, thanks, Leslie, and thanks for all those questions. I think it's a case of we kind of watch this space and see, but make sure that as we're progressing in the right direction, which, as Alex says, I think we're already on the front foot with a lot of the aspirations that are outlined in the independent review report. So I'm sure this will be coming back to the IJB as this develops further in due course. Okay, so we're just asked to note that report, so we'll do that for the minute. Next item is on whistleblowing updates. Is it Martin that's going to speak to this report? I see you're there, Martin. Yeah.
Yes, thanks, Chair. Thank you. The purpose of the report is to provide the IJB with, firstly, an update on the recently introduced national whistleblowing standards, and also to present a draft whistleblowing policy for the IJB. So starting with the standards, they have been produced by throughout Scotland by the Independent National Whistleblowing Officer and came into effect on the 1st of April. The Partnerships leadership team received a presentation on the launch of the standards ahead of the 1st of April and have since communicated the standards across the partnership. We will continue to work with NHS Grampian to communicate the standards across the partnership, and that includes commission services and the third sector, as well as signposting staff to any additional training on the standards held on to us. In terms of reporting of the whistleblowing incidents, those that are captured through the process will be reported to both the IJB and NHS Grampian on a quarterly basis, and it is proposed that the Risk Audit and Performance Committee receive the quarterly reports. Moving to the IJB whistleblowing policy, officers from the partnership were communicating with the Independent National Whistleblowing Officer regarding the production of a whistleblowing policy for the IJB. The Independent National Whistleblowing Officer's view is that although IJBs do not have to have a separate policy, it would be good practice to establish such a policy. As a result, an IJB whistleblowing policy has been drafted and is attached at Appendix A. The policy relates to all IJB members and office holders of the board and is committed to dealing responsibly, openly and professionally with any genuine concerns held by staff of the Aberdeen City Health and Social Care Partnership, members of the board or office holders, encouraging them to report any concerns about wrongdoing or malpractice within the IJB which they believe has occurred. If approved, it is proposed that any whistleblowing incidents raised through the policy will be reported to the Risk Audit and Performance Committee by the board's standards officer on a quarterly basis. The report recommendations are in front of you, and I'm happy to take any questions on the report. Thank you.
Thanks, Martin, for that overview. I'll open that up for questions now. John Cook.
Thanks, Lauren. Recommendation 2.4 as written basically says if there have been any incidents, we'll get a quarterly report. So if there weren't any incidents, we wouldn't get a report. So I'm wondering if, even if it's a kind of two-liner that says there's been nothing this quarter, that would be quite helpful for the RAPS committee, maybe. Because what I'm thinking, I'm thinking back to the banking sector pre 2007, 2008. Before that, you'd probably see very, very few instances of whistleblowing in banks. That didn't mean that everything was hunky-dory. What it meant was that people weren't blowing the whistle. So I think we need, again, maybe for the RAPS committee to have a kind of annual look at things like, is everybody aware of what the policy is? Do people feel comfortable in blowing the whistle, or are people worried that if they do blow the whistle, they might get victimized? So it's kind of, I'm not suggesting there's a load of bad stuff going on, but I just think it would be helpful to have that assurance.
Martin?
Yeah, thanks, Councillor Cook. The Risk Audit and Performance Committee does get an annual assurance report, so we'd be happy to include that in there if that would be helpful. And interested to get the views of the IJB in terms of whether you'd want to receive a quarterly report to the RAP committee, even if it's a nil return report.
Yeah, I think the including the stuff in the annual report would be good. In terms of the quarterly one, to be honest, I was kind of thinking out loud. So, and I'm actually thinking, if it's a nil return, do we get a one page that says nil return, which might not be that terribly helpful. But there's some other way of just reporting we've had nothing this quarter. It could just be a simple email from you, Martin, maybe.
Yeah, that's a good idea, or also we could maybe include it in a service update as well to the members of the RAP committee.
That works for me.
Okay, so can we ask Martin just for you to go and have a think about the most sort of realistic way of doing that? And I suppose what I'm hearing from John, and I'd absolutely agree, it's not about we've had nil reports. It's actually, are we proactively making sure people know about the policy and that people feel that they can report? So there's other indicators that are probably more important, and that could, I suppose that could be covered in the annual report in terms of training that's been provided, awareness raising for staff and those kind of things, because they're probably more assuring to me than a nil return or a whatever every quarter. So Martin, if you can give some thought to how that would be covered, and I will now move on to, I see John Tomlinson and then Sandra MacDonald.
Yeah, thank you. It was just on this item that Councillor Cook has raised. Maybe Martin can think about just using the business planner, because if it's in there for each quarter and there's nothing to report, it could just be a simple phrase added into the business planner. But that's just a suggestion. Alex and Martin might have a different way you want to do it.
Yeah, happy to look at that. I think that would be a good way forward as well. And just can bring that up at the committee at the appropriate time. Yeah.
Thanks, John. Sandra.
Thanks, Chair. I just wanted to ask, the policy is to be reviewed on a 5-yearly basis. I just wondered why 5 years, I suppose, what the thinking was behind that, and whether there would be a table put into the policy as we go forward over the years. And of course there might be a change if there was a change in other circumstances that comes before 5 years, I guess. If there would be a table highlighting the changes to the policy, so just a small table in the policy, just saying what had changed at a particular time.
Thank you,
Sandra. Martin.
Yeah, thank you, Councillor MacDonald. I think that to answer the first question about why, I think if we were looking at the whistleblowing policy that the council have been using, but I'm happy to look at bringing that review to a quicker timeline, but also I think going back to what Councillor Cook was talking about, that would be part of the kind of overall assurance annual report on insurance. So again, if IJB members wanted a quicker review time, we can do that, include that in the annual review. But also when the review does come through the committee, then yeah, certainly happy to highlight any changes that are made that have been made to the policy.
Thank you, Chair. Can I also ask, secondly, around how we benchmark with other areas? Will there be in the annual review maybe looking at, if we're coming up with 0 whistleblowing episodes, which just to make sure that is benchmarked with other areas in Scotland? Is that something you're thinking of?
Yeah, I'm happy to look at that. When we went through the officers to get the advice, obviously it's best practice to have the policy. So I'd need to go back to see how many IJBs across the country have introduced a similar policy. But then, yeah, happy to look at the kind of the data coming out of those IJBs to compare.
Thank you.
Thanks. And thanks, Sandra. I see Alison.
Hi, yes, it was just looking at it about the difference between grievance and whistleblowing. I was just looking at some of the examples about grievance, and I don't think there's even the examples, I don't think there's necessarily a clear distinction. For example, complaints about insufficient training, couldn't that also be under creating or ignoring serious health and safety risks? To, it just seems to be not, the examples seem to create a clearer distinction than I think there actually is. Maybe it's just me.
I think in terms of the policy, obviously, if there's any whistleblowing incident will come through to myself as business manager as defined in the policy, and then it's a discussion with the IJB's standards officer, as opposed to really get to the bottom of the incident, whether it's a whistleblowing incident or whether it can be undertaken through other policies. So yeah, maybe the examples are difficult to really differentiate, but I think that kind of discussion between the business manager and the standards officer will hopefully get to the bottom of exactly what the incident is, and then report it through the correct channels.
Okay, thank you.
Okay, thanks everyone. I don't see any other hands up, so we'll go to the recommendations now. So I'll just go through them all. So the first one is note the action taken to communicate the national whistleblowing standards that come into effect in April this year. Instruct the Chief Officer to report on a quarterly basis on any whistleblowing incidents raised under the new standards to the RAP Committee and to NHS Grampian Board. Consider and approve the draft whistleblowing strategy policy for the IJB Appendix A, so we're content to approve that. Yeah, I'm seeing nods for that. Instruct the IJB Standards Officer to report any whistleblowing incidents raised under the IJB's policy to the RAP on a quarterly basis. But we can look at the wording of that, Martin, to just be to any activity in relation to whistleblowing or whatever's going to be most appropriate, so that remains visible. And the other point was just to consider the timeline for policy review, maybe to add that in the minute, not necessarily a recommendation, but that I think that the feeling, maybe the question was whether 5 years is quite a long time to leave it, but for that as an action for you to go and look at, would it be appropriate to come back in a shorter time frame for a review, and we'll make sure the minute captures the desire for benchmarking with other areas, so we get that kind of wider assurance that what's happening locally are signals of positive things. So is that okay? People happy with that? Derek?
Thank you, Chair. It's just for the clarity around the 2.4, seen as we are making a decision, and it is a suggestion that we instruct that the report goes quarterly on any whistleblowing activity via report and or service update as is appropriate.
Yeah, I think that's fine. Martin, are you happy with that? It gives you a bit of flex to just go away and have a think about what's going to be most useful. Okay.
Yeah, thanks, Chair.
Okay, thanks, Derek. That's helpful. Okay, so we'll now move on to our next item on the agenda, which is the market facilitation update. Is that going to be Anne Mackenzie? And Anne, do you have a guest with you today?
I do. Well, I think I can see Mike Burns on the call.
Thanks, Anne. Then over to you, and to introduce Mike to everyone too.
Okay, thank you. So I'm assuming that everybody has had enough time to read the report, and I think some of the aspects within the report links to the earlier conversations about the that were covered around the Feely review, and hopefully within the paper you'll have some more evidence about how we've been collaborating or approach towards engaging with the market. I have with me today, I hope he's on the call, Mike Burns, who is the chair of the Granite Care Consortium. Here he is. And I think, hi. So Mike's just going to come along, or has been asked to come along, just to give a brief overview of how market engagement has felt from a provider's perspective. So if it's okay, Mike and I haven't rehearsed this, so if I go through my report and then I'll just pass on to Mike, Rowan, if that's okay. So you'll note from the report that this paper has been presented later than had been anticipated, but that was agreed by the IJB previously. We have paid reference to the Feely report, and that although we don't know the outcome of how the recommendations are going to be implemented, I thought it was appropriate to pull out some of the some of the aspects around the relationship that we would be expected to have with our providers. You will see that we've continued to commission services throughout the past 18 months, which has been a significant ask of both the partnership and providers themselves to commit to working collaboratively to commission services. And I've listed the services, the key services that we have commissioned, and I can update that we've successfully procured our sensory services, and that North East Sensory Services will be continuing to provide care for people with a sensory impairment over the next 5 years. You'll also note the significant amount of support that's been offered to the social care sector throughout the COVID pandemic, both through the different aspects of oversight that we've had to put in place for our residential and non-residential services, but also at a very operational level through the formation of our provider huddles, which really have been invaluable over this past 18 months in terms of keeping people going, and also, I suppose, other aspects, for example, how the sector accesses protective personal equipment. We have had several market engagement events, and we're continuing to learn from that process and refine that process as we go along, and we will certainly be implementing that process, and our commitment to working collaboratively with providers as we commission services in the future remains. As Alec alluded to earlier, we have identified that we have a gap, for want of a better word, at a strategic level, and we have had an initial workshop with leaders from the social care sector and ourselves, try and establish the best means of progressing a strategic forum for the future. I think that's all I want to say on the report. I'm happy to take any questions, but perhaps take those after people have heard what Mike has to say.
Yeah, thanks, Anne. Mike, welcome to Aberdeen IJB. It's really great to have you with us. It was really important when we were talking about this that to get a sense from the provider's experience of how it's felt, and if there's lessons to be learned from an IJB as how we go forward with this approach. So over to you, and yeah, I'm sure everyone will be interested in what you have to say. Thank you.
Thank you, Lauren, for the invite to the meeting this morning, and welcome, folks. I'm Mike Burns. My day job is the CEO of Aberdeen Cyrenians, but I'm also the co-chair and one of the architects of Granite Care Consortium. It's been really interesting listening to you. I mean, Leslie earlier raised something about the detail around the work that's been done in taking forward programmes such as Care at Home, and I also listened to some of the comments from members around how that detail looks, and hopefully I can give you some of that. It was mentioned earlier that from Alex that the executives see themselves as being on the front foot when it comes to Feely. I'd actually think they're being too modest on that one. I actually believe that you're ahead of the curve. When you read Feely and you read that what we've established with the Granite Care Consortium commissioning process, which was carried out during the pandemic, which was the right thing to do in order to get the services in place. We've actually established something that will look to address market stability. Will look to move forward and address the time and task way of working and moving forward into an outcomes-based model. We are now talking to IT providers on how we can actually establish real-time measurement as far as outcomes are concerned for the people that really matter here, our service users. And also going forward, what we're doing is that we're moving to a collaborative system where as a consortium, we're able to handle the pressures that come in relation to care at home collectively, which gives us so much more ability, agility and scope to be able to do that. And a good example of that is how we're only 8 months, and sometimes I've got to remind myself that we're only 8 months since we established Granite Care Consortium, but already we're starting to reach our targets, and already we're starting to look at moving people forward from the unmet need list in the city and into Granite Care Consortium, and already talking about how we deal with the oncoming pressures of winter this year, which could be quite considerable when you think about the impact of COVID-19. But happy to take any questions, and I mean, I could talk all day about the detail around Granite Care Consortium, but from a provider's perspective, working alongside the executive team has actually been very, very constructive and very productive. And I do think that as a joint initiative, you know, Granite Care Consortium is not just a commissioned service delivery vehicle, it's actually a group of people that actually want to work alongside the executive team and achieve change, positive change for the service users around care at home in the city of Aberdeen.
Thank Mike. That's fantastic to hear that experience. I'll open it up now for colleagues to have any questions or comments back to Mike or Anne on the paper. Leslie. There's a few sticky mic buttons. There you go.
Got there. Thank you, Chair, and thank you, Mike. It's really positive to hear, you know, what you have to say, I think, in terms of, and to remind us as well, it is only 8 months since, you know, this got underway. I suppose with my, I just wanted to hear, is there challenges here in terms of, for some partners, maybe to do with scale, in terms of how well they can engage? Because that was the thing that struck me really, you know, at the outset.
Definitely, Leslie. There's been some challenges in establishing Granite Care Consortium in the midst of a pandemic. You know, we have had some challenges in relation to staffing, and you know, and we're looking at how we deal with that going forward. But the strength of the consortium has allowed us to share that responsibility over 10 members. So what we're able to do is something that we didn't do before, was we were able to collect data, and now we're giving the partnership more detailed data regarding the number of people we work with, the breakdown of those groups and the needs of those individuals. And we're hoping to keep that rolling forward and enhancing that data. But one of the biggest challenges, Leslie, has been around making sure that we can put adequate staffing into the delivery of GCC, and where one individual organisation can't do that, then we've got another 9 members to lean on to make sure that we support each other, and that really does bring the collaborative approach into its own.
Great, that's really positive to hear. I mean, I have been aware of, obviously, the way in which people have really pulled together during the pandemic, but it's good to hear at the detail in terms of, you know, that a lot of this helps to provide more data, which then obviously, in terms of if we're trying to have evidence-backed services and outcomes, it all works really well towards that, and the whole spirit of collaboration really that's being engendered here. So thank you again.
I see Anne had her hand up. Anne, did you want to come in?
Just very quickly, I suppose what I was hearing, Leslie, as well, was around opportunity for people to engage in a collaborative approach to commissioning. So it was just to, I suppose, just to reassure you that we make every effort possible to allow people the opportunity to engage. So, for example, we have a piece of work that we'll be progressing over the next couple of months. And you know, we've advertised that opportunity as widely as possible, but certainly, and I know that Maggie's on the call. You know, if people are struggling, then we do what we can within what we're allowed to do to be able to engage with people, and you know, around the pieces of work if people are struggling to come through, because I have to respect that not all organisations are as big as each other and maybe don't have the infrastructure, and that's been one of the beauties perhaps within the provider huddle. You know, we've been able to, it's a shared platform. People, you know, if people have the means to engage, then we've been able to engage them in that process, but also looking out for people perhaps who haven't engaged. You know, they've been able to contact our provider escalations team, say, for example. So access is being made available to people in different ways to allow for that to happen.
Thanks, Anne. That's really helpful. John Cook and then John Tomlinson.
Thanks. Yeah, it was that was really helpful. Just wanted to get your feel for how successful we've been in measuring outcomes. I think measuring outcomes is absolutely the right thing to do. That's how we should be looking to do stuff rather than just looking at process and inputs. But I just it can be harder to measure. So just interested in your thoughts on that.
Yeah, I'll take this one. Mike, will I start with this one just from a general point of view, and then so you're right, John. It is a significant shift, and it's something, and we don't have a route map as insofar as, at the best of my knowledge, not everybody has progressed in this way. What we're trying to do is take a mix of qualitative and quantitative evidence. So in the past, key performance indicators would have been purely around numbers, which describes footfall to you, or the size of a package of care, but not necessarily the impact on the individual. And one of the things that we're very interested in is using, say, for older adults, say, for example, is using something called the life curve, which you may or may not have heard about, which is it's an opportunity to understand people's physical function. There's a score associated with it. It's well used by our allied health professional teams, but we've now incorporated that into our care management assessment. So as people assess for care, they'll be able to show a starting point, and then I'm sure Mike will go on to talk about as an enabling approach is put in place. We should be able to see an end point, which should help us see that there's been a difference in what people are actually functionally able to do. We're also looking at perhaps using the IROC tool for people with a mental health condition, so that we can start to, and in my head, it's then a shared language across our multidisciplinary teams, which then pulls in our operational teams and provider organisations, really focusing on a person's outcomes rather than each individual team doing their own thing, which is potentially where we might have been in the past. So I think it's a work in progress, but just to reassure you that we have got a key focus on that and making that happen. But I'll let Mike just add to that if necessary.
No, thank you for the question, John. It's a very relevant one, because there's been a number of tests of change across Scotland where they've attempted to try and measure the outcomes for service users, and they've remained reports on tests of change. Nobody's quite been able to scale it up in the way that we want to do with GCC across the city of Aberdeen. And that's really, really important for us. And that was a central tenet of the model, the consortium model. Given that this is the first of its kind in Scotland, I mean, the city of Aberdeen needs to be congratulated on taking, having the courage to take this step. But we're confident that within the next 4 weeks, we'll announce a partnership with an IT provider that will allow us to measure the tests of change, starting around enablement, step up and step down models for service users in our care at home model. And that test of change will run from September on to January of next year. At that point, and the most important thing for me, John, is being able to then scale that up across the whole of GCC. So we'll take the evidence from that test of change, then start the scaling up early in the new year. And we're confident that sometime in 2022, we'll be able to start to measure the outcomes for all service users within the GCC population, which will be the first of its kind and the first to be established across the whole of Scotland around care at home.
Thank you, Mike.
Thanks for
that. John Tomlinson.
Okay, thank you, Chair. Just 2 points on this. Very much welcome the report and obviously all the work that's gone in to get us to this position. First point, just linking back to earlier question around the Feely report. I think this does put us into have a strong option that if the executive team are keen to carry on commissioning, that we are doing it in a way which is robust and in line with the direction of travel. So you know, personally, I would be able to support them readily if that was their choice. Second point would be that we're not backward at being forward in presenting nationally what is happening here, because it's actually delivering, as Mike has indicated to us, you know, the stability, the outcomes, and now getting into handling the pressures and reallocating cases, etc. I mean, that's basically what we were. That was the conceit of this whole thing at the start, and to get there at this stage is really impressive. And I would be concerned that potentially the drive for national standards undoes some of the important local work. So I think I would like, if it's possible, if Anne and Sandra can put some time into presenting this into the national, wherever those discussions are, so that it's not missed, because it is impressive where we've got to.
Thanks, John. That sounds like a very sensible advice and suggestion, which I'm sure Anne and Sandra will take up. Do we have any other questions from anyone? No. I see, Maggie, you've put a comment in. Maggie, is there anything you'd want to come in and say? You mentioned in the chat about the IT development from the TSI perspective.
Well, I was listening to all the questions there, and there wasn't anything that I felt that I could say apart from just to really add the support of the TSI and sort of congratulations really to the work that's been done. It wasn't I'm sure everybody who's involved in the process knows that it wasn't a painless process at all, and I think it's really wonderful to be able to come out the other side. And I thought when the discussion on the Feely report was going on as well, I really felt that, you know, I'd like to add my voice to the view that actually the IJB and the manner of working here in Aberdeen City is beyond the level that's being talked about as a sort of advanced level in the Feely report. So it was really I just wanted to say the IT stuff sounds really exciting. I'm looking forward to hearing about that. But really, I think that credit goes to the perseverance and the determination of the people involved in this as they've gone through to try and actually produce a completely changed model that reflects the modern world that we're in. And I just want to say that we're with you on it, and future developments. I find the members of the Health and Social Care Partnership very open to having transparent discussions about what happens around these things, and hearing from providers and hearing from service users. So we would just try and share as many of those opportunities possible to allow people to come in and get their voices heard. And there is a real appetite, I feel, for co-production. And there's nothing really more than that other people have said, but I just want to add that in. And congratulations to Mike on his new job.
Thank you, Maggie.
Great, well, thank you. And if I can ask that we record formally our thanks to the Granite City Consortium for taking the step to come together. It's a new way of working, so there are risks involved for providers there. So just our huge appreciation for the work that you've done in the lead up to the contract, and indeed over the last 8 months from the IJB. We look forward to hearing how this progresses, but we're really delighted to hear how well it's gone so far. And I remember, and I'm sure other IJB members will remember, last year it felt like it was a really important decision we were taking during COVID, but we were well, we knew, we were convinced it was the right thing to do, but it felt like a very brave decision. So I think it's really helpful to have the feedback and have that loop coming back to us to confirm that, you know, we were right in taking that brave decision. And yeah, great to hear progress. So thank you, Mike, and thanks to all the consortium and to Anne, of course, and the team for taking this forward. I'll also just want to record our congratulations to North East Sensory Services for securing their contract, which will give stability for 5 years. So that's excellent news as well. So I think on the actual paper, we're being asked to note the paper, and I would also note that there is a report coming back to the IJB in December on the broader work, Anne, as well. So are people happy that we note that, and we can move on to our next item? And thanks again, Mike, for your time today. Thank you.
Great.
Okay, Derek.
Oh, fine, happy with that, Chair. It's just to highlight the time. It is 11:25, and I don't know if that is an appropriate time that you would wish to consider for your break.
I'm wondering if we do one more item, if people are agreeable to that, the Health and Care Experience Survey. And then we'll have a break after that, because we've got some pretty big items coming too to discuss in the latter part. So if with everyone's agreement, nobody's sitting really looking uncomfortable, we can carry on for a few more minutes and do the Health and Care Experience Survey paper. Is it Alison today that's going to speak to this paper?
Yes, it is, Luann, thanks. Hi.
Hi.
So this report is on the biannual Health and Care Experience Survey. It was actually requested by the IJB in November 2019, and I don't think anyone imagined at that point either the delay that we would have to getting the results of the survey, or indeed the changed landscape of service delivery that has come about in the interim. The details are in front of you in the report, but I think it's important to note that these particular results are 18 months out of date, and they are also they also relate to a period pre-COVID. We will bring forward a report on the next Health and Care Experience survey in July 2022, and we're also due to undertake our own local survey next summer at the end of the current strategic plan, and we'll bring forward a report on that to the December IJB next year. Both of those survey results will provide more meaningful data to identify areas for improvement to feed into service planning and delivery. But in the meantime, I'm happy to take any comments on the report in front of you.
Thanks, Alison. I see Alison Murray wants to come in. Alison?
Hi, yes, it was really about the little colour coding of the report, because as you say, the data's out of date, but as just as an approach to it, I noticed it was like above average, Scottish average or above average, nice and green, and then below. And I just felt that when you have only like 34% saying that they, oh, sorry, I'm trying to read it on the screen, well, 34% saying, I think it's about support for continuing care, and it's yellow because it's sort of at the average. I don't think that's really, it doesn't strike me as a good sort of approach to doing it, because 34% is very, very low, and I don't think to say, well, it's average, so it's fine. It just feels wrong.
Thanks, Alison. Yeah, the RAG status was purely and simply a comparison. The Health and Care Experience Survey is one of the few opportunities that we have to benchmark our performance against both against the national average and indeed against our previous performance. So the RAG status was purely and simply a comparison against, as you say, both the national average and against our percentage. So it's a RAG status on trend, if you like, you know, on whether we are improving or not. But absolutely take your point in terms of you know, if we're only getting 34% positive in any one category, then we must do better on that.
Thank you.
Thanks both. John Tomlinson.
Yeah, thank you. Alison's point was really exactly the same as what I was looking at. I understand the RAG as an indicator, but those last percentages scream out. And I think even though it's some distance in time, it does suggest that there's something substantial needs to be addressed in terms of the next strategic plan and what our targets are going to be. And I know we've had a recent retendering around that service. But in due course, it'd be interesting to see what our target percentages should be around this and what we would want instead of these percentages.
Thanks, John. Yeah. See Alison nodding to that as well. Sandra MacDonald.
Yeah, I suppose it was just on that data table as well, and it just because we don't have what the Scottish 2018 figure is, it was difficult to know if that had shifted or not in that particular year. So you couldn't really get a trend in my. Well, I couldn't, you know, I just wasn't quite sure how helpful it was in some of that data. And I suppose my other question or comment really, I suppose, was around the one which we were most adrift in percentage wise. Certainly I knew that healthcare professional well, and I just wondered how that could ever be properly measured, or I just, you know, it's just what is my perception of knowing somebody well compared to somebody else's perception. So maybe you could fill me in a little on what that particular line in the report is telling us.
So in terms of the questions, these are set nationally, so we don't have a huge amount of influence over that. And you're absolutely right. You know, it's individuals responding to the questions that they're given without a huge amount of context around about it. So it's very subjective, you know, and we each might answer that question differently. So it's very difficult to get consistency across the board in responses. Absolutely, I might say if I've seen a health professional once before, I know that person, whether that's well or not, you know, but I'm seeing the same person again. But, you know, others, you know, they might want to see the same person for a few times before they say they know that person well or not. So it's difficult to give definitives, and they are very subjective responses.
So I suppose my question is how helpful is the data then? Does it tell us very much? You know, I was struck, I suppose, by you know, some if we're trying to get to more real time on some stuff, and then we're looking at here, and to be honest, my note in the side says something that was a long time to wait, but I understand the COVID aspect of that as well, and then I just thought, I mean, how relevant is some of this data again?
I guess the only positive point is we're measuring the same thing time and time again. You know, so it's the same question being asked, and it's individuals that are responding. So whilst there will be variations of interpretation and variations of responses, at least it's the same random every time, if that's any consolation.
Thank you.
Thanks. And Sandra, maybe you should have said at the start, this was really closing off an action that was on the IJB planner, and I felt that we should see it because we'd agreed we would, even though it was well out of date. Probably the more important thing is the comparison with next year because of the experience of going through COVID. But yeah, normally we wouldn't be looking at data this out of date for sure. Philip.
Thank you, Chair. So my question is also centred on the data that's presented in this tabulation, and I really don't think the colours are at all helpful. My reasoning is this: so if you look at, for instance, treatment or advice from GP practice, I was listened to, 91% is red. However, if you actually look up to the top of the table, ease of contact in GP practice, 91% is green. If you then look a couple of points down, the last time you need to speak or to see or speak to a doctor, 84%, and yet lower down, that's red, lower down 84% is amber. So I really don't know actually what those colours are telling us, and if they're needed at all.
So the RAG status is on the trend, or the comparison against the Scottish average and the trend from our previous score. So if we're below Scottish average, and or if we have reduced from our previous percentage, then that gives us a red status. And similarly, if we're above average or if we've improved, that gives us a green status. So that was just my interpretation of how to present that information. But I can certainly reconsider the way it's presented in future.
Thanks. That would be quite useful, I think. Thank you.
Thanks, Philip. And I think probably on the various questions on the RAG status, there's probably something we could just maybe note in the minute about considering looking at a different way of presenting that in future. Because I know myself, I understand absolutely the trend and the comparison with other areas, but there's just something in me that goes to red. Like if there's something red, you think that must be bad. What's that about? And actually, that takes away maybe from some of the other important parts of the data there. So yeah, maybe just consider looking at a different way of presenting it, which doesn't take our eye off in the wrong direction. Might be a helpful thing. But I don't see any other questions from anyone. And just to note, we were very conscious that this was, well overdue coming, but we wanted to close off that loop. If I can go now then to the recommendations, and if anybody has anything you want to add, please put your hand up. But the first one is to note the summary comparison results from the Heath survey undertaken in 2019-20, and to instruct the Chief Officer to bring a report on the 21-22 survey in July, and comparing these with what we have in front of us today, which will give us the pre and post COVID experience. And finally, to instruct the Chief Officer to bring a report on the results of the local survey in 2022 to the December 22 meeting of the IJB. People content with all that? Yeah, I'm not seeing. Okay, so we can close that one off and have these new actions. Oh, John Cook.
Sorry, I was just thinking about this. If for the future, if we do change the way things are presented, could we have a comparison with the new way of presenting and the old way of presenting, so you can compare apples with apples and not apples with pears? So I'm just sorry, it was just listening to the as the conversation, and sorry to prolong this one, but if you've got something that this time was red, say, and next time it's amber, you'd be saying, oh, we're getting better. But in fact, it might just be that we're presenting it in a different way. Sorry to overcomplicate things, but just a thought.
Yeah, we don't want to lose sight of trends or improvements or benchmarks. So it's a way of combining, being able to give us that information in a meaningful way, but not lose the comparison with previous years. Yeah, I'm sure Alison and
thanks, John. I'll
see
if I can meet that challenge. Thank you.
Sorry, Alice. Let's go. I don't know what the answer is, but I'll leave it to you.
Thanks, everyone. So I'm sorry, we've run over a little bit after 11:30. Derek, what's your thinking? Should we stop for 10 minutes and come back at 11:50? Does that give everyone enough time? Just over 10 minutes to stretch legs, get a comfort break. And Derek, do we just, Leslie? Did you want to say 5 minutes? Leslie's suggesting 5 minutes. We come back at 1:45. People happy with that? Quick pit stop. Yeah. Okay. Derek, do we just switch our cameras off but stay on the call?
Just switch the cameras off. I will stop the recording and do a two-part recording, so that there's a split.
We'll see you all in 5 minutes. Thank you.